Hi, I'm Chris Kuenze, and I'm an associate professor and clinical researcher at the University of Virginia. I'm excited to talk about some of the recent work that we've published in JOSPT about normative values for patient-reported and functional testing in adolescent patients with ACL reconstruction. The reason we did the work is that we've talked to patients and physical therapists over a series of qualitative and mixed method studies. And one of the bits of information that's consistently come back is that patients don't have a good understanding of how they're progressing relative to peers. And physical therapists lack access to sort of quantitative information to provide to patients to help guide their rehabilitation and help them feel as though they understand where they are in their rehabilitative process prior to return to sport. So our purpose was to develop some normative values for common measures that are utilized in the return to sport process for patients who are transitioning out of clinical care. We had a multi-site design with 3 universities and 2 children's hospitals. And a mixture of data sources, both prospective cohort studies and retrospective chart review studies that were combined to build out these normative values. Our inclusion criteria were that patients needed to be between 12 and 20. They needed to be 5 to 7 months post-ACLR, and I'll explain why in a moment. And we needed to make sure they had no surgical complications that would have resulted in a second procedure or have delayed their care in a meaningful way. And you can see on the right side that we had a breakdown of sample between sites that was highly weighted towards 3 of our sites, but hopefully in future projects that will balance out a bit more. The reason we chose 5 to 7 months was based on a project by Burroughs et al. Recently that indicated in the United States that most patients disengage with the rehabilitation process somewhere between 16 and 20 weeks after ACL reconstruction, which corresponds well with the time point that we've included. And we see that that is, younger patients get a little bit more care, maybe up to 20 days or 22 days of physical therapy, but at the same point, still relatively close to that 5 to 7 month time point. And so we had a reasonable breakdown of male and female patients, and we also see that the majority of patients in the sample were between 15 and 17, which was expected because this is a period of high risk and high exposure to high risk sport. We had a number of different measures, both patient-reported and performance-based. So we had isokinetic strength, we had HOP assessments, and then a series of the most common patient-reported outcomes that were used. It's important to note that for the IKDC, some sites collected the adult IKDC and others collected the PD IKDC. And so in our normative data, that's clarified. Both are presented independently of each other. And so the results of this study are a bit difficult to interpret from these graphs on the left side, right? We've got a number of different measures. We've got limb symmetry indices and single leg assessments for like hops and strength. But we can see that we've got at least the mean and standard deviation within our large sample for each assessment, along with the sample size ranging from 300 all the way up to 450. And then we also present the data in percentiles. So these are the data that correspond with everything from the minimum value to the maximum value, and each percentile at 10% increments from there on out. On the right side, we see a more tangible way to use the data. So this is our dashboard that we've built out. It's freely accessible at the QR code, and clinicians can enter their patients' data into the dashboard, and it will automatically change the values in the overall sex, age, and sex by age columns to compare their data to the normative data presented in our paper. The next steps in our process are that we'd like to consider additional surgical characteristics. We'd like to make sure that we've got healthy normative values so that we're comparing patients not just against others who have had an injury, but also against individuals who are of similar age, sex, and activity level, but have not had an injury. And then we'd also like to enhance our sample size and the diversity of our sample size to include folks from different races and ethnicities, regions of the country, socioeconomic statuses, and age groups. And in order to help make this work a bit more accessible, we're in the process of publishing a web-based version of this tool. It'll be published at acldashboard.com, and we're hoping that this will go live, at least for adolescent patients between 5 and 7 months within the next month. We're also hoping to expand out to other time points and other age groups in the near future. This work was a team effort. It took a tremendous number of people, a tremendous amount of work to get it done. And so I do want to say thank you to all of them. And thank you to you for listening to my presentation.